Okay, so now we're going to be moving over to the paralleling technique, and this is on chapter 17 of your dental radiography textbook. Let's first go over the learning objectives of this chapter. First, we'll define the key terms associated with the paralleling technique. We'll state the basic principles of paralleling technique and illustrate the placement of the receptor, beam alignment device, position indicating device, also known as your PID, and the central or primary ray. We'll discuss how object to receptor distance affects the image and how target to receptor distance is used to compensate for such changes. We'll describe why a beam alignment device is necessary with the paralleling technique. We'll list the beam alignment devices that can be used in this technique and identify and label the parts of the REN XCP instruments. We'll also describe the different sizes of the receptors used with the paralleling technique and how each receptor is placed in the bite block. Also, state the 5 rules of the paralleling technique, as well as describe the patient and equipment preparations that are necessary before using this technique. We'll discuss the exposure sequence for 15 periapical receptor placements using the paralleling technique, and we'll also describe each of the 15 placements recommended for use with the REN XCP instruments. We'll summarize the guidelines for periapical receptor positioning and explain modifications in this technique that is used for patients with things like a shallow palate, with bony growths, or a sensitive premolar region. So we'll list the advantages as well as the disadvantages with this technique. So the purpose is to present basic concepts and to describe patient preparation, equipment preparation, and receptor placement procedures used within the paralleling technique. This chapter also describes some modifications that can be used in patients with certain anatomical conditions and outlines the advantages as well as the disadvantages of this technique, and as well as some reviews and helpful hints. So the 3 concepts of the paralleling technique are, the technique is also known as, this technique is also known as the extension cone paralleling technique, which is the XCPs that we use in class, the right angle technique, and the long technique. So the paralleling technique is one method that can be used to expose periapical or PA and bite wing image receptors. Some terminology you'll want to know are parallel, intersecting, perpendicular, right angle, long axis of the tooth, and central ray. Central ray, as we all know, is just that primary beam of your X-ray cone. The long axis of the tooth, we're talking about from the tip of the tooth or the tip of the apex all the way down to the incisal edge of the coronal portion. Right angles is just when you have 2 lines that intersect at a perpendicular angle and create a 90-degree angle. Perpendicular just means the same thing. You're creating 2 right angles. Intersecting is when you have 2 lines that come together. And paralleling is when when moving or lying in the same plane, always separated by the same distance and not intersecting. So we have 3 principles of the paralleling technique. The first is that the receptor is placed in the mouth, parallel to the long axis of the tooth being radiographed. The central ray of the X-ray beam is directed perpendicular to the film, so it creates that 90-degree angle. So perpendicular to the film and the long axis of the tooth. A beam alignment device must be used to keep the receptor parallel with the long axis of the tooth. So if you look on page 153 on figure 17-3, it talks about, or it illustrates rather, what that paralleling technique looks like in the mouth, and what type of perpendicular right angles need to happen from the primary beam all the way to the long axis of the tooth and through to the receptor. So these are a couple of rules that must be followed to obtain accurate images. The object to receptor distance must be increased to keep the receptor parallel with the long axis of the tooth. So if you look on page 153 on 17-4, we'll see what it looks like if you have the object to receptor distance too close. You end up with an angle that is not parallel, and we can see this on A of 17-4. So what you'll need to do is to increase the object to receptor distance, and this will help to keep that parallel angle. Also, the target to receptor distance must be increased to ensure that only the most parallel rays will be directed at the tooth. So a beam alignment device is a device used to position the receptor in the mouth and retain the receptor in position during the exposure. Paralleling technique requires the use of this type of beam alignment device in order to keep the receptor parallel to the long axis of the tooth. Some examples of commercially available intraoral beam alignment device is the RIN XCP extension cone paralleling system, which is what we have in class. And then also something called an XCP Aura, which stands for one ring and arm position system. And on page 154 on figure 17-5, rather 17-5B, we can see what an XCP Aura looks like. And you can see that this type of holder is also color coded, so that red always means bite wings, blue always means anterior PAs, and yellow always means posterior PAs. But this is sort of a convertible type of holder that you can kind of use one system and kind of just change it and move it through the different slots depending on what type of image you need to take. So a RIN XCP DS Fit universal sensor holder. I believe there's also one on that same picture. Let me just make sure. I don't think it's actually on that picture there. So that's one of them that's not in there. There is a DS Fit universal sensor holder. And that one is, maybe that one's not on there either. That's okay. So moving on to the next one, RIN flip brace system is on that picture, and that's item C on 17-5. And what that is it just uses a rotating bite block in a ring. And this is another model that eliminates multiple devices. A RIN snap array holder is my personal favorite, and we have two variables of this type of instrument, and this is D and E of that picture. You see that one actually has, it looks like the exact same picture there. In the class, you'll notice we have one of them where the anterior holder is at an angle, and the other one where it's flat. So the one that's at an angle is the one where we'll use for a paralleling technique, and the one that has a flat holder is something that we'll use for a bisecting technique. A stabe bite block is item F on figure 17-5. And the stabe is another positioning device that can be used. The nice thing about a stabe is oftentimes they are made of cheap styrofoam and they're disposable. So that helps with cross-contamination and making sure that we're keeping up to standards with infection control. The bad thing about that one is sometimes they're kind of hard to keep in the patient's mouth unless your patient has ideal anatomical conditions. A lot of times using a stabe can be sometimes more cumbersome than what it's worth. So the way that film holders reduce exposures are, one, they prevent cone cuts, and this reduces retakes, and also allows the film to be held in place without the aid of the patient's finger or more importantly, your finger. So once again, XCP stands for extension cone paralleling. All right, so RIN XCP extension cone paralleling system. So this is just 3 plastic bite blocks. Comes with, so we have 3 different bite blocks. You got 3 different plastic aiming rings and then 3 different metal indicating arms. None of these can be interchanged with each other. The type of indicator arms go with a certain bite block, which goes with a certain aiming ring. So you can't interchange either of them. They're all in a color-coded system, and they all have to use the same color. Once again, the XCP or Aura is just a 1 ring, 1 arm type of device where you can just use one device. You just have to switch it around, and it comes in different configurations depending on what type of or which area in the mouth you're imaging. An XCPDS fit is a bite block that includes self-adjusting clip that stretches to accommodate the size of a digital sensor. And then a flip brace system is just, like I said before, a rotating bite block. So another universal holder that can you can use to take in different areas of the mouth. You just have to configure it differently. And then a RIN snap array holder, there's 2 versions. So one is for films, and then one is used for digital sensors. And that was the one, those are the 2 different variations that they have on figure 17-5. They both have that angled edge for paralleling. And just one of them is designed for films and one is designed for sensors, but they both do the same thing. So the size 1 receptor, this can be either a film or a digital sensor, is used in the anterior region. And this is almost the same size of a size 0 receptor, which is used in a pediatric case. But this is just a little bit more narrow. And it's used so that the long portion is in the vertical direction, so that when we take pictures of, or excuse me, images of anterior teeth, we're only taking 1 to 2 teeth at a time. And so size 2 receptor is used in the posterior region. And this is this is where the long portion is in the horizontal direction. So the film is, or the receptor is kind of laying down in that horizontal configuration. You always want to ask the dentist what type of or excuse me, what size of receptor to use and how many anterior exposures they want. So rules for paralleling technique. So 1, the receptor must be positioned to cover the prescribed area of the tooth to be examined. So all of the teeth that you want to examine must fit within the borders of that receptor. The receptor position must be positioned parallel to the long axis of the tooth. The receptor and beam alignment device must be placed away from the teeth and toward the middle of the oral cavity. Vertical angulation is when the central ray of the X-ray beam is directed perpendicular such that you create a right angle to the receptor and the long axis of the tooth. For horizontal angulation, the central ray of the X-ray beam must be directed through the contact areas between the teeth. So incorrect horizontal angulation results in areas that are overlapped and therefore non-diagnostic. The film receptor exposure is when the X-ray beam must be centered on the receptor to ensure that all areas are exposed. If you don't center your receptor in your primary beam, you'll end up with what's called a cone cut. And we can see a picture of what this looks like on page 155 on figure 17-7. So in this case, it looks like the receptor was placed just a little left to the primary beam. And that resulted, excuse me, and this one looks like they had the PID to the left of the receptor. So this results in a cutoff film. And so we can see we have a couple teeth in this picture, and then the rest of it is just a blank film where radiation did not expose that part of the image. So before exposing any receptors, the infection control procedures or all infection control procedures must be completed. So patient preparation, after completion of infection control procedures and preparation of the treatment area and supplies, the patient should be seated. After the patient's seated, you'll prepare the patient before the exposure of any receptors. Equipment preparation means that after the patient is prepared, the equipment must also be prepared. So this is done before the exposure of any receptors as well. The exposure sequence for receptor placements. So regarding this, the dental radiographer must have an established exposure routine to prevent errors and to use the time efficiently. So you always want to establish a sequence for placing or for exposing your X-rays. So typically, when you're doing paralleling techniques, you'll always start with the anteriors, and you'll start the same way that you read, right, from left to right. We'll start from the top, and then we'll work our way to the bottom, and then we'll go on to the posterior section, also from the patient's right or your left, and you'll start from the upper right quadrant, and you'll go on to your lower left quadrant, and then from there you'll switch to your upper left quadrant and then your lower right quadrant. So if you deviate from the sequence that you stick by, there's possibility of you overexposing the same area or missing an area that you should have exposed. And this will result in having to take the patient back into the X-ray room, possibly retaking more images and exposing your patient needlessly to more radiation. So the receptor placement for the paralleling technique must be positioned before exposure, and this is dictated by the specific teeth and the surrounding structures that must be included in the image. So for patient preparation, the procedure includes, you'll want to explain the procedures, first of all, to the patient, explain what it is that you're going to do and what teeth that you're going to be taking pictures of. Also, you want to adjust the chair such that their chin is level with the floor, and adjust their headrest so that you have that same result. Place and secure the lead apron and remove all objects from their mouth. So this includes any tongue piercings, lip piercings, gum, any retainers, any dentures, any partial dentures. Basically everything has to be removed from their mouth. For equipment preparation, you want to set the exposure control factors beforehand. So you don't want to do this while you have the receptor in the patient's mouth. Then you want to open the sterilized package, which contains your beam alignment devices, and assemble the devices over a covered work area. And you typically want to do this in front of the patient because you want them to see you rather open that sterilized package, and put that together in front of them so that there's no questions as to whether or not those devices are clean. So if you're taking an anterior exposure sequence, a size 1 receptor is small and easier for the patient to tolerate, and this is going to be less likely to cause them to gag. So there are going to be a total of 7 anterior placements using the size 1 receptor. So you're going to have 4 for the maxillary or upper arch, and then 3 for the mandibular or lower arch. For the posterior exposures, you're always going to have 8 posterior placement exposures, 4 on the top teeth, and then 4 on the bottom teeth. You'll always begin with the anterior teeth, and then, like I said before, stick to a sequence And don't interchange the sequence from patient to patient. You'll just get confused and you'll forget which teeth you've taken a picture of and which ones you still need to. So you want to make this a habit for all of your imaging exposures. All right, so the specific area where the receptor must be positioned before exposure is dictated by teeth and the surrounding structures. And the specific placements described in this chapter are for 15 receptor periapical series using a size 1 receptor for anterior exposures and size 2 receptors for posterior exposures. So I just want you to pay attention to that because in class we almost always use that size 2. So if any of you are getting confused while we're taking so many, in the book, it's because they're explaining this over a size 1 receptor for anterior exposures, which would require more a bigger total of, or a bigger number of x-rays that need to be taken. So have the PID close to the patient so positioning of the ring will be quick. And then also remind the patient to hold still during exposure. Wanted to go over something really quick. If your patient isn't still during exposure, especially if you have a small child or somebody that's fidgety, you can have, this will result in a blurred image. And that's not really a diagnostic image and something that would need to be retaken. And you'll be surprised at how many people don't realize that you actually need to be extremely still for x-rays. So just kind of make sure that you remind them in a gentle, friendly way, of course. So some modifications in the paralleling technique will be necessary if your patient has some or certain anatomical features like these. So your patient might have a shallow palate. They might have some bony growths, or the mandibular premolar region might be more sensitive. So it's very important for the dental radiographer to be competent in dealing with these type of situations because they will show up. Using cotton rolls and changing the vertical angulation and the location of the receptor placement will assist the radiographer in taking a dental image of diagnostic quality. So if you have a patient that has a shallow palate, cotton rolls are going to be your best friend. 2 cotton rolls can be used at a time. 1 can be placed on either side of the bite block. Also, vertical angulation can be increased by 5 to 15 degrees if you have to. And sometimes you have to, especially with these dexters in our lab have extremely shallow palates. So in some sense, it's good that we're getting that type of practice because you'll be able to get over or find ways around how to take images with somebody with a shallow palate. So bony growths, we have something called a torus, or tori plural. So a maxillary torus is basically just an overgrowth of bone that is on the roof of some people's mouths. If your patient has a maxillary torus, the receptor must be placed on the far side of the torus and then exposed. So if they have mandibular tori, typically the lower jaw has 2 tori. The receptor must be placed in between the tori. So in between the tori and the tongue and then exposed. So if you look on figures 17-23 through 17-26, it'll show pictures of what a maxillary torus looks like while you're trying to take x-rays, and then also where that receptor should be placed in relation to that torus or those tori. So in the mandibular premolar region, sometimes this area can be really sensitive, especially if your patient has some type of gum disease or they're having some type of cavity or abscess down there. So if this is the case, the receptor should be placed under the tongue. So sometimes you'll have to actually ask them to relax their tongue so you can push it out of the way a little bit. This will give you more access to the middle of the floor of their mouth where you'll have more room to place that receptor. So the lower edge of the film can also be softened to prevent discomfort. So certain dental supply companies sell a special sticky foam that can wrap around the edges of the film so that it won't cut the patient's tissue. So some of the advantages of the paralleling technique are number one, accuracy. This is because the image is free of any type of angular distortion, and so you'll have a straight on shot, as they call it, from their receptor all the way through the tooth and onto the PID. Also, it's simple, so it eliminates the need to determine horizontal and vertical angulation. And if we can get those XCPs to work on your patient's mouth, it's almost like a simple plug and play situation where you just put that thing in the receptor's mouth, you line it up with the PID, and you hit the button. And if everything works out right, it eliminates chances of dimensional distortion. So also, for duplication purposes, um, comparison of serial images can be very useful in your practice. So, for example, if you have patients that have cavities that might be developing, we can take a duplicate image of that same tooth 6 months from now. And if you're using a paralleling technique with an XCP holder, more than likely that duplicate image is going to be exactly the same. So that way we can compare what that cavity looked like 6 months prior and what it looks like now. So the primary advantage is that with the paralleling technique, it produces an image without dimensional distortion. Some disadvantage of this technique is that the receptor placement may be difficult. Unless your patient has typodont type teeth, or they don't have any tori or any other weird anatomical features in their mouth. A lot of the times this type of placement can be difficult. And that's because it's this, not only is it difficult to place the, the beam alignment device as well as your receptor, but it's also uncomfortable for the patient. This is because that beam alignment device itself might cause some discomfort for the same reasons we talked about before. If your patient has some sensitive mandibular premolar areas of their gums, that bite block is pretty rigid, and it can be pretty abrasive to that area. So any difficulties can happen, and they can happen with pediatric patients or adults. So being aware of how to get around these type of situations are going to be really, really valuable to you as you grow in your careers. All right. As always, if you have any questions, feel free to email me or come talk to me in class. Thank you for listening. We'll talk next time.